So again, welcome everyone to the Orlando GI Journal Club. This is November 2nd, 7 a.m. Eastern Standard Time. Good morning to everyone. So the first study that we're going to be reviewing this morning has been a fairly controversial study, at least in the GI community. It is the large randomized trial that was published in NEJM by Brett Hauer et al. It's looking at the effect of colonoscopy screening on risks of colorectal cancer and related death. This study is important in our clinical practice because colorectal cancer is the third most common type of cancer and the second leading cause of death from cancer worldwide. And multiple screening options are available, but high quality evidence to indicate the best strategy is limited. So the aim of these study investigators conducted this randomized trial to investigate the effect of population-based colonoscopy screening program on the risk of colorectal cancer and cancer-related death at a minimum of 10-year follow-up. And this is known as the Nordic European Initiative on Colorectal Cancer. So again, this was a randomized trial conducted in 4 countries: Poland, Norway, Sweden, the Netherlands. What these authors did was that men and women aged between the ages 55 and 64 years were invited to participate in the study. The participants had to have had no previous screening colonoscopies, and the participants were identified from population registries in one of the 4 countries. They were then assigned in a 1:2 ratio to either the invited group, which means that they were invited to undergo a screening colonoscopy, or the usual care group, which means that there was no invitation and there was no screening colonoscopy performed. The randomization occurred actually before the participants agreed. And patients with diagnosis of cancer after randomization were excluded from the study. The follow-up was at least 10 years and ranged from 10 to 15 years. The primary outcome measure was looking at the risk of colorectal cancer and risk of death from colorectal cancer, and the secondary outcome was to look at death from any cause. So these are the baseline characteristics. As you can see, 84,585 patients participated. In the invited group, 28,000 patients ended up agreeing to participation. And there were 56,365 patients in the usual care group. The female-male ratios were evenly split, and as were the age when they split it into 55 to 59 versus 60 to 64. The adenoma detection rate overall was 30.7%. The sequel intubation rate was 96.8%, and 91% had good or very good bowel preparations. The risk of adverse event was also fairly low in this study. There were no perforations observed, and there was a 1.13% incident of major bleeding. So what the authors did when they were performing the statistical analysis was an intention to screen analysis. So this meant that the patients were, once they were divided into either the invited or usual care groups, they were followed, and the results, their outcome, clinical outcome, whether they had cancer or whether they died, were contained within those groups, regardless of whether they actually underwent a colonoscopy or not. So what was surprising and what caused a bit of controversy in the last couple of weeks is that the incidence of colorectal cancer fairly low in both groups. So if you look at the invited group, the 10-year risk of cancer is 0.98% in the invited group versus 1.2% in the usual care group. This is a risk difference of 0.22%. And as you can see here, the risk ratio is significant, a risk ratio of 0.82, which means that if you're in the invited group and you underwent screening colonoscopy after agreeing to do so, then you had an 18% lower risk of developing colon cancer. And we know this risk ratio is significant because if you look at the 95% confidence interval, it does not cross 1. So it ranges from 0.7 to 0.93. If you look at death, though, from cancer specifically or from any cause, again, the rates are fairly low, 0.28% in the invited versus 0.31% in the usual care group. However, the risk ratio is not statistically significantly different. However, the risk ratio, which means that you're trying to see if you're in the invited group, whether you have a significantly lower risk of dying from colon cancer, this risk was not statistically significant because even though it's 0.9, and therefore you can say, well, if you're in the invited group, you have a 10% decreased risk of developing colon cancer. If you look at the 95% confidence interval, it ranges 1. Okay, it spans 1 and goes from 0.64 to 1.16. Again, the same story for death from any cause. So 10-year risk was 11% versus, again, 11% for the usual care group. And again, the risk ratio is 0.99 with 95% confidence interval spanning 0.96 to 1.04. When they calculated the number needed to treat means how many patients you have to treat for a specific disease, or, in this case, how many patients have to undergo a screening colonoscopy to prevent one case of that particular disease. In this case, colorectal cancer. The number they calculate is 455, which means that 455 patients have to undergo a screening colonoscopy to prevent one patient from developing cancer. When they performed a per protocol analysis, they adjusted analysis to estimate the effect of screening if all the participants who were randomly assigned to the screening had actually undergone screening. Because remember, they tried to do a pragmatic randomized trial, which means that they assigned the patients they already randomized the patients before the patients even agreed to be in the study in the first place. Then they found that the risk of colorectal cancer at 10 years was 0.84 in the invited group, which is lower than in the intention to screen analysis. And the risk of death from colon cancer was 0.15 in the invited versus 0.3 in the usual care. And if you take the per protocol analysis, this risk reduction is actually statistically significant in the invited group. So obviously this is a great, it's a big randomized trial. It's clearly multi-center. It really is multinational in the traditional sense of the word. And they tried to do a pragmatic trial design whereby randomization was performed prior to consent to participation. And the authors state that this design is a more accurate reflection of a population screening program because not everyone who is invited for screening will agree to undergo screening procedure because it is voluntary. But they do note that because of this specific trial design, the benefit of screening may be underestimated, as the traditional study design assumes 100% participation in screening programs. Also, the authors in the discussion do state that the absolute risk of colorectal cancer, and even more so of colorectal cancer-related death, were lower than in those in previous screening trials and lower than anticipated when the trial was planned. And they anticipate this by stating that there may be a declining risk of colorectal cancer in recent years, and also maybe it's because of an appreciable improvement in prognosis of colorectal cancer due to better treatment options. So in this large, pragmatic, randomized trial, the risk of colorectal cancer at 10 years was 18% lower in individuals who agreed to undergo a screening colonoscopy after an invitation to do so, compared with individuals who were assigned to no screening. although the absolute incidence of cancer was low in both groups. And also on the same note, they found that there was no significant difference when they performed an intention to screen analysis between the two groups in the risk of death, either from cancer or all-cause mortality. All right, this is our next study. This study was published in Inflammatory Bowel Disease, and it's looking at ulcer size after induction therapy to look at 1-year endoscopic remission in Crohn's disease. This was a post-hoc analysis of previously or ongoing randomized trial. This was by Prey et al. In Crohn's disease, the objective measure of disease activity are known to be better at predicting long-term endoscopic remission compared to patient-reported symptoms. However, it remains unclear if patient-reported outcomes, such as abdominal pain, stool frequency, etc., provide additional prognostic value in patients with persistent endoscopic inflammation. So the aim of this study was to evaluate whether the persistence of ulcers on endoscopy following an induction therapy with biologics is associated with a decreased likelihood of endoscopic remission at 1 year, and whether patient-reported outcomes provided any additional prognostic value among Crohn's disease patients with persistent endoscopic inflammation. So this was a post-hoc analysis of results from the clinical trials Unity and Extend. And they looked at Crohn's patients and took patients with ulcers that were at least 5 millimeters in size at baseline. And in these studies, these patients then underwent induction therapy with either ustekinumab or adalimumab. Sorry, it's still too early for these biologic names. So then assessed the variables, which were simple endoscopic score for Crohn's disease, SES-CD, and looked at ulcer sizes in 5 bowel segments. And then they assigned scores according to the size and number of ulcers, with the scores above 16, meaning they had severely active disease, and low scores obviously indicating inactive disease. Patients then reported outcomes. They also looked at patient-reported outcomes, PROs, of abdominal pain, stool frequency, and feeling of general well-being. The outcome measures were to evaluate possible association between the presence of ulcers, at least 5 millimeters in size, and endoscopic remission at 1 year in patients with baseline ulcers of at least 5 millimeters. So as you can see, they have enrolled 283 patients in this study. If you look at the location of the large ulcers, they were primarily located in the ileum, followed by descending colon, then rectum, transverse colon, and then ascending colon. The treatment received what ustekinumab and adalimumab, as stated earlier, because they were specifically taken from those studies investigating these two biologic agents. And the median SES-CD score at baseline was 12, and those were the baseline characteristics. Oops. Next, they then looked at the impact of post-induction ulcer size on 1 year endoscopic outcomes. So when they looked at outcome of endoscopic remission, they found that the ulcer sizes were the presence of ulcers and the ulcer sizes as a variable were negatively associated with endoscopic remission. When they, at all scores, when they set the SES-CD score of less than 3 of 0, and also were negatively associated with endoscopic response, with odds ratios of 0.2, 0.17, and 0.38. Oops. They then looked at the impact of post-induction affected surface on 1 year endoscopic outcomes. And when they looked at surface inflammation and Crohn's disease surface affecting at least 50%, They were also significantly negatively associated with endoscopic remission, but it was not a significant factor looking at endoscopic response. When they looked at post-induction affected surface of greater than 75%, it was a significant variable and negatively associated with endoscopic remission and endoscopic response. They then looked at impact of post-induction patient-reported outcomes on achieving 1-year endoscopic remission in patients who had ulcers of at least 5 millimeters at baseline. And the main thing to note here is that all of those symptoms that patients report, abdominal pain, increased stool frequency, feeling poor, terrible, etc., have absolutely no significant impact, which means it was not a significant variable impacting endoscopic remission. The limitation of this study is that there is possible selection bias because they included patients with a CDAI of 220 to 450 only in Unity and Extend trials, and therefore they, by default, exclude patients with mild or very severe symptoms. The timing of post-induction endoscopic assessment was not consistent between the two trials. It was week 8 in Extend and week 12 in Unity. Multiple comparisons were made in the study, and therefore there is a possibility that statistical significance may be due to chance alone, and it was a 1-year follow-up only, and therefore there is uncertainty regarding duration of therapy with biologics prior to evaluation for endoscopic remission. So the take-home point is that Crohn's patients with ulcers of at least 5 millimeters after induction therapy are less likely to achieve 1-year endoscopic remission and post-induction PRO severity. So post-induction and patient-reported outcome severity did not offer additional prognostic information. Therefore, objective measures such as endoscopic features are more important than subjective features, such as patient-reported outcomes to predict a 1-year endoscopic remission following induction therapy in Crohn's patients. Next is a study by Wiss et al. It was published in the Annals of Internal Medicine, is looking at the adenoma detection rate and risk for interval post-colonoscopy colorectal cancer in a fecal immunochemical test-based screening. So adenoma detection rate, or ADR, is defined as the proportion of colonoscopies in which at least one adenoma is detected. And in previous studies, it has been shown to be inversely associated with post-colonoscopy colorectal cancer with ADR target of at least 25% set as the adequate performance measure when colonoscopies are performed in patients with low prevalence of adenomas, such as those undergoing regular screening or surveillance colonoscopies. But patients with positive FIT tests have high prevalence of adenomas, and therefore you're likely to get high adenoma detection rates in this setting. So these authors wanted to evaluate the adenoma detection rate in a large group of endoscopists in a Dutch FIT-based colorectal cancer screening program and assess the association between adenoma detection rate and interval post-colonoscopy colorectal cancer incidence. So these results are taken from the Dutch colorectal cancer screening program. The Dutch CRC screening program is set in a way whereby patients or participants individuals aged 55 to 75 years undergo a biennial FIT test. Then colonoscopy is performed if you have a positive FIT test. During colonoscopy, any detected lesions are resected in the usual manner, and then further treatment and follow-up surveillance colonoscopies are performed per guidelines. So these authors included all FIT-positive patients who underwent first colonoscopy from 2014 to 2016 without a prior diagnosis colorectal cancer in the following 6 months, and then followed up these patients for a median of 52 months, which is about 4.5 years. And the primary outcome measure was the incidence of interval post-colonoscopy colorectal cancer. So as you can see, they had 116,360 patients between 2014 and 16 who underwent screening colonoscopies by 362 endoscopists after they had a positive FIT test. Then they ended up with 103,900 patients who were included in the final analysis. So these were the results. So 103,900 patients underwent screening colonoscopy after a positive FIT test. And as you can see, the incidence of no lesion was 17%, advanced adenoma was detected in 39.7%, non-advanced adenoma in 32.6%, and serrated lesions in 3.4%. They found post-colonoscopy colon cancer in 426 patients and interval post-colonoscopy colorectal cancer in 209 patients. When they looked at risk factors for interval post-colonoscopy colorectal cancer, the significant variables were age, with increased risk with increasing age, which makes sense. And the only other really important significant variable was the adenoma detection rate, with increased risk with lower adenoma detection rate with p-value of 0.001. This can be alternatively interpreted as greater your adenoma detection rate, lower your risk of having your patient having a post-colonoscopy CRC. So they then looked at the cumulative number of interval post-colonoscopy cancer incidents per 1,000 colonoscopies, and they plotted according to the adenoma detection rate. And as you can see, this is cumulative number of interval cancers here per 1,000 colonoscopies. This is years since colonoscopy. As you can see, the greatest incidence are with the lowest adenoma detection rate. This curve responds to 55%, versus this line here, which represents 70% adenoma detection rate, and the number of interval colorectal cancers is the lowest. The main limitation of the study is that there is a relatively short follow-up duration of only about 52 months, and interval cancers can still develop in patients who may have been given a 10-year surveillance period. And the study is based in the Netherlands with a specific FIT positive cutoff of 47 micrograms of hemoglobin per gram of feces, and specific age mixes. Therefore, results may not be generalizable to all the countries worldwide. So the take-home point of this study is that adenoma detection rate is inversely related to interval post-colonoscopy cancer risk in colonoscopies performed after positive FIT test, and supports the use of adenoma detection rate as an important quality indicator for endoscopists performing colonoscopy in all cancer screening programs. Adenoma prevalence is higher after FIT positive test compared with colonoscopies performed for other indications, and therefore ADR target for colonoscopies in FIT positive tests should be increased. Our last patient was published in Gastroenterology. This is by Vogt et al. And it's looking at intestinal ultrasound to determine endoscopic response and remission in patients with moderate to severe ulcerative colitis. Intestinal ultrasound is non-invasive. It's easily accessible, does not require bowel preparation, and is a low-cost method of visualizing colon in UC patients. and therefore there is some interest as it may be a good tool for monitoring disease activity in point-of-care settings. But data are scarce on the accuracy of intestinal ultrasound in determining disease activity in the in the UC. The aim of the study was to look at the accuracy of intestinal ultrasound in evaluation of treatment response after tofacitinib in patients with moderate to severe UC with endoscopy and histology as the gold standard. This was a prospective study of patients over the age of 18 with moderately severe UC and endoscopic Mayo store of at least 2 in at least one colonic segment who were started on tofacitinib. And patients were assessed at baseline and then at 8-week post-treatment after treatment initiation, and they looked at the simple clinical colitis activity index and the Lick Tiger score. And they also measured other inflammatory markers such as CRP, fecal count protectin, and white cell count. Intestinal ultrasound was performed at baseline and at week 8 post-treatment initiation. All segments, including rectum, were visualized, and then they measured the bowel wall thickness in the longitudinal and cross-sectional planes. In the study, then colonoscopies were performed in all patients at baseline at 8 weeks with biopsies taken. And they looked at the endoscopic Mayo score and UC endoscopic index of severity. The primary outcome measure was to look at the bowel wall thickness in the sigmoid colon in patients with endoscopic improvement versus no improvement after 8 weeks of treatment. So in the study, it's clearly very small. It's more like a pilot study looking at this possible novel diagnostic tool. And so 30 patients were enrolled. As you can see, 23 patients of patients on biologics were on were on 3 biologics. They also then looked at endoscopy at baseline. These were the severities, kind of baseline findings. And if you look at the intestinal ultrasound parameters at baseline, in sigmoid colon, the median bowel wall thickness was 5 millimeters. They had loss of wall layer stratification in 33%, lymph nodes present in 27%. In the descending colon, the bowel wall thickness median was 4, with loss of layer stratification in 26%. So then they looked at bowel wall thickness and sigmoid colon in patients with and without endoscopic response as determined by their colonoscopies. As you can see, the bowel wall thickness, which is this y-axis here, at 8 weeks of tofacitinib was significantly lower in patients who had endoscopic improvement compared to those who did not, with p-value of less than 0.0001. When they looked at endoscopic remission, according to the endoscopic Mayo score, again, the same pattern, bowel wall thickness significantly lower in patients with endoscopic remission versus those who have not. And then this again is looking at endoscopic remission again, but using a different score, the UCEIS score. Again, bowel wall thickness is significantly lower compared in patients with endoscopic remission versus those with those without endoscopic remission. They also looked at percentage change in bowel wall thickness in the sigmoid, as you can see. In patients without endoscopic response, the percentage change was around 10%. But if you look at the percentage change of bowel wall thickness in patients who have undergone endoscopic therapy, the percentage change is much higher, almost 60%. And this is the same pattern, whether they were using the Mayo score or the UCEIS score. The main limitation of this study is that this is a small study, and it was performed in a tertiary academic center with limited generalizability. They had only one treatment agent for the patients, tofacitinib, in the study, and 8-week maybe and early time point to assess endoscopic treatment response. The main take-home point is that intestinal ultrasound with bowel wall thickness measurement shows promise for evaluating treatment response in patients with ulcerative colitis. So this is the recap. In large pragmatic randomized trial, risk of colorectal cancer at 10 years was 18% lower in individuals who agreed to undergo screening colonoscopy after invitation to do so, compared to individuals who were assigned no screening, although the absolute incidence of colorectal cancer was low in both groups. Crohn's patients with ulcers of at least 5 millimeters in size after induction therapy are less likely to achieve 1-year endoscopic remission, and post-induction patient-reported outcome severity did not offer additional prognostic information. Therefore, objective measures such as endoscopic features are more important than subjective measures. Adenoma detection rate is inversely related to interval post-colonoscopy cancer risk in colonoscopies performed after positive FIT test, and supports the use of ADR as an important quality indicator for endoscopists performing colonoscopy in CRC screening programs. Adenoma prevalence is higher, however, after FIT positive test compared to those compared with colonoscopies performed for other indication, and therefore ADR target for colonoscopies in FIT positive patients should be increased. Intestinal ultrasound with bowel wall thickness measurement shows promise for evaluating treatment response in patients with UC. Again, thank you so much for joining us this morning. Our next monthly Orlando GI Journal Club will be the first Wednesday of December, which will be 7th of December. I thank you so much. All right, thank you. Please have a wonderful month.